2021 virtual conference. So glad you all are here. My name is Mona Bormet, and I'm the program director at CCIH. We are glad you could join us for our virtual 2021 conference. We look forward, of course, to being able to meet in person soon, but we're grateful for having this technology to bring us together now. Right now you can see a slide that has the 6 days of our conference, and soon you will see a slide with instructions for how to access the interpretation channel in French and Spanish. So we hope those who need it can join that way and listen in. Just so you know, we will hold all questions until the end of the program today, which will be in approximately an hour and a half or so, before we go into networking and breakout rooms. And we will collect all questions until then. So please use the chat box to ask your questions, and we will have staff monitoring that. And we are so grateful for our sponsors who have helped make this conference possible. And so our gold sponsor today is World Relief. And World Relief is a global Christian humanitarian organization that brings sustainable solutions to the world's greatest problems, including disasters, extreme poverty, violence, oppression, and mass displacement. World Relief partners with local churches and community leaders in the US and abroad to bring hope, healing, and transformation to the most vulnerable. So we're very thankful for World Relief's support and partnership. And now I will turn it over to our moderator for today's session, Allison Flynn at World Relief. Allison is a senior health and nutrition technical advisor. Excuse me. Allison is currently based in Malawi, where she provides technical support to World Relief's family-centric health and nutrition portfolio at the global level, with specific emphasis on programs in sub-Saharan Africa. Allison holds an MPH from the University of Illinois at Chicago with concentrations in global maternal and child health and community health sciences, and a BA in international relations and human needs and global resources from Wheaton College. She also serves as co-chair of the CCIH Health of Women and Children Working Group. So thankful that Allison could join us from Malawi, and I will turn it over to her. So welcome, Allison.
Welcome, everyone. I'm Allison Flynn, and if you are new to CCIH, we are an international health and whole nutrition perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. So this session is being recorded, and it will be posted.
Hi all, sorry about that. It looks like Allison is having technical difficulties, but that seems to happen. So she was just giving a quick introduction to CCIH and that the session is being recorded.
I'm back.
You're back. Okay, great. Go for
it. Sorry about that. The session will be posted on CCIH YouTube channel in a conference playlist, and you'll find links to the recordings on the CCIH website at ccih.org under events. It's a really great resource to be able to go and look back at it later as well. So today, I'm very excited to share that we'll be discussing the theme of community ownership and co-creation. As someone who works in community health, this is a topic that comes up almost daily. For me, the ways that we engage with communities, from critical in children, youth, people in housing conditions. This is
Hi all, it's Mona again. It looks like Allison might have gotten kicked off again. So sorry about that. We'll see if she joins. I know that she is a huge fan of community ownership and co-creation, which is why we asked her to moderate this session. I will just go ahead and introduce the first speakers, and with hopes that Allison is able to join again soon. So our first speakers for our session on unity and community ownership and co-creation today we'll be discussing the power of communities in health. So an interview of Sister Dr. Priscilla Busingye, an OBGYN in Uganda, by Dr. Tonny Tumwesigye, who's the Executive Director of the Uganda Protestant Medical Bureau. So Priscilla has been working with the poor and vulnerable in Uganda for over 30 years. She came into the world on the dirt floor of a modest hut in the Tumwesigye district of Western Uganda, and has been committed ever since to advancing the health of pregnant women and their families. I have been having many conversations with Priscilla over the past few months, and it's been such a joy to learn from her. She is the first African sister and woman to win the L'Chaim Prize, which she received in 2020 for her outstanding missionary work in Western Uganda. And I know she will be a blessing to others as you hear and learn from her today. And Dr. Tonny, the Executive Director of Uganda Protestant Medical Bureau, also a longtime CCIH member, so glad he is here today. And before he became the ED of UPMB, he served for 10 years as the CEO and medical superintendent and a frontline physician at Kizizi Hospital, which is a 250-bed mission hospital in rural southwestern Uganda, where he oversaw the expansion of the hospital's community health insurance program into the largest self-sustaining community health insurance scheme in Uganda. And through his dedicated leadership, Tonny has guided UPMB to earn the Grant Thornton Institute of Uganda Corporate Governance Award for the NGO category. We are so happy to welcome Tonny and Priscilla today to the conference, and I will turn it over to the two of them for their conversation today about the power of communities in health, especially using Uganda as an example. So over to Tonny and to Priscilla. Welcome.
Thank you.
Thank you very much, Mona. Good afternoon from East Africa. Good morning, US, and good night in maybe another country that we may not know. Dr. Priscilla, Dr. Sister Priscilla, congratulations again upon your success and winning the ACHAP Initiative 2020 prize. For your deep commitment to serve mothers and children. Dr. Sister Priscilla, you continue to amaze me with your zeal to serve. May you share with our viewers and listeners what motivates you in the work that you do?
Thank you very much, Dr. Tonny, and viewers and all the CCIH team. I'm really honored and very happy to be here this afternoon to share with you, and thank you for the congratulations. I just want to say what motivates me is the smile in the face of a woman who's been miserable for years because of like incontinence of urine in fistula, a birth injury, a cry of a very asphyxiated baby who has been resuscitated by a midwife. Those key things motivate me just to improve the quality of life. And when I had just finished my master's as an obstetrician, I just felt like, let me go to the community and make advances in maternal health. But I just found myself like I was a fire extinguisher in the community and I wouldn't think beyond emergencies. But I did find something that motivates me, which I feel like sharing. And my desire was to make publications, become a professor. But then after prayer, I just said the best way is to make the quickest publications, and that's making a difference in every woman's life. And so every time I would make a difference, put a smile, help a baby, I felt that that's a big publication made, stored in people's hearts, but read by God. And that's, I think, the biggest motivator for me. And of course, seeing in every patient the face of God. I must say today was a testimony. I had a virtual background before we started. And then I said, no, this is not okay. Let me download another one. And it all failed. And the computer said, your device cannot allow. And I'm like, yes, today is the community. So those are the key small things that you make me motivated, just make a difference in people's lives. Thank you.
Wow.
Yeah.
Thank you very much for sharing that, and for us to know really that it's not money, it's not anything, but it's about service to humanity.
Yes.
But of course, as you know, today's session is focused on community ownership and co-creation. Can you please share an example of how you engage with communities where they are co-creating with you and your teams on community-based projects?
Yes. So when we started this whole working with the community, we've discovered some places where people are coming under the tree to seek health care. And we decided to say, let's look what is their challenge, where are their problems. So in co-creating together, we try to go to the community. The community identifies its own challenges and its own problems, and together we work together to seek for solutions. We sit together, discuss, agree on solutions, agree on developments. We just don't come with some new idea and impose it on them. We seek all these things together. Of course, there are some things which the community may not be aware of. For example, the girls dropping out of school, getting pregnant early. So we had, as a religious congregation of sisters, try to start a school so that we can hold these girls in school for a little longer. And that's the way. The key thing is to identify problems together, challenges together, find solutions together with the community. That has been the powerful thing that has helped us to move ahead together.
Wow.
Yeah.
So community engagement, planning together, thinking together, setting goals together.
That's right.
That's quite interesting. So at Rubare Health Center in southwestern rural Uganda,
Yes.
Can you please share more about the work that you are doing at that health center?
Okay, so it started an Uganda system. As you know, others who don't know, we have health center 2, 3, 4, then general hospital, and then the regional referral. So we started as health center 2, we went health center 3, and now we are just at the health center 4. And now we are looking forward to make it. we have a big dream to make it a world-class hospital in the rural where everyone can access care of a specialist care on diagnostic tools. So what we are doing, we are training nurses, we are training human resource healthcare workers. We are doing birth injuries in terms of camps in the community, especially to relieve the suffering of women who delivered under unskilled health attendants. And we repair the fistula, we repair genital prolapse. And not only that, we have our partners, African Mission Healthcare, and they try to fund women who cannot afford a cesarean section to avoid more problems in the community. We do clinical audit to set standards for healthcare workers and also to train the young doctors in the community. And we only actually don't work in the Royal Health Center. We have made it a big thing in the Western region because of the Lakaim praise that we received, so that we can make sure the whole region is covered and gives standard care, just to leave a legacy in people's hearts and, you know, to feel honored, respected, and have care within their communities.
Well, thank you very much, Sister Priscilla, for that. I think from what we used to study in medical school, that was the bottom-up approach that you are doing, but also from what you're sharing, it's a classical undertaking of a community diagnosis. You basically diagnose the community together with them,
True.
And then you are now responding to the needs of that particular community. If there are other countries out there that would otherwise want to adapt or learn from what you're doing, what lessons do you have for them?
The key thing, I think, is to recognize that everyone is important. Every human being is important. What the powerful thing that we have done is to use the local people within their community. And when we talk of the local people, we don't mean ministers or LCs or anything. We mean the border riders, the vocal people in the language, the respected elderly people in the language. They have wonderful ideas. And those are ideas that we have built on to reach where we are, and we continue to use them. Another thing is that we need to overcome some problems by trying to involve the community. Once we involve them, we are accountable, we are transparent. I think that's important. But also we need to brand ourselves. If you are Christians, brand yourselves as Christians and make sure you have an icon. For example, CCIN in the virtual background, it's well nice thing, but I decided also to get mine and say Jesus on the cross is the one who helps communities. So we need to have our icon put right, and also to know what we want, set our values right, but keep meetings. We have a team, a community committee that helps to come and even evaluate what healthcare workers are doing within their community. So in that way, the people own their facility, own every program that they are doing. And even when there's a problem, they're the first ones to come and share with you that, no, we have identified something here. And then you stretch your hands towards that. Have I answered you?
Yes, you have. Thank you. I think that is very, very important. I also know that from the experience that we've had in the past, while you were leading a hospital in the western part of the country, and I was also leading a hospital in another part of the country, issues is that there is always going to be some challenges.
True.
There are some challenges that you faced that may be unique to the work that you're doing, and how have you been able to deal with them?
So in the community, the biggest challenge we had definitely is funding, because this dream is a faith-driven big dream where we actually have 30% now of our big dream, but we know our God is able. So the issue is to share our dreams with the community. The challenges of human resource, we are overcoming them by training. And sometimes when you train someone, you think the person is going to stay there. Sometimes they run away and go elsewhere. But that one, we are okay with it. We don't mind, because wherever they will go as people we have trained to serve that community. Challenges of equipment have been there, but we are also overcoming them by buying one thing at a time. It's brick by brick and you reach somewhere. And for example, next week I'm going for the surgical camp. I didn't have a theater table. Can you imagine, as a surgeon, how do you arrange a surgical camp without a theater table that can perform the way you want? But after sharing that, immediately there was someone to say, no, we can get you this. And indeed it has arrived. So it's sharing our big dreams, sharing what we need, and then things start working. But one thing at a time. It cannot all be 100%. Maybe even after this conference, I have many of you who want to be part of a big dream, and we are there to say, yes, let's work together to make a difference. Yeah.
Thank you, sister, for that, and for dealing precisely with the things, not losing heart, not losing focus, and remaining committed to the cause. And yes, as rightly put, Jesus, our Lord, is always at the back of our mind, giving us that extra parting. Maybe something you may want to share with our viewers about, I don't know, about the politics of the area, the terrain. Are there any challenges that you faced with the districts, the national level, the structures?
So right now, as the president of Association of Gynecologists of Uganda, it gives me an opportunity to know a number of things that happens all over in our country and beyond. And in the place where we decided to say, let's make a special maternity center, it's because it was in the remote region. This is where you reach a regional referral after like 3 hours drive on the road. And you can imagine a woman who is pregnant in labor, and there are no means of transport, and gets a contraction on a border. You first sustain sometimes an injury before you arrive, and then you are pregnant. So in our process, we said, no, I think this is the place in the rural, people can work in their place. So some places are hilly, the water is a challenge, and that's why in our project, water is the first thing we said, let's first have water running. It may not help the communities, but those communities around us and those people who come to the health center, they can have running water. And probably also the poverty around people, it's like an underserved community. People can only get funds when they have had their plantations and they take for sale. And that takes like 3 months, 4 months to get some money, and they have to pay school fees. And that's even the more reason why we decided to look for partners who can help us at least fund emergencies. So and some of them are refugees from Congo because we are close. And also we are close to Congo border through the Bundibujo, and also we have refugees from Rwanda. So it's quite a place that really needed assistance.
Wow, thank you very much. I know we are coming towards the close of our time, but there are a couple of few other areas that I want us to explore together. Because, sister, there are a number of issues from our communities that tend to affect the work that we do. For example, faith. How are you managing the different faiths in the community that you're serving, including the traditional faith, and where people should not be looking at you as as helping them to convert them towards your faith, but looking at it from a holistic perspective. How are you handling that, sister?
Yeah, very good and very good question. One would imagine that this is a facility headed by maybe nuns and they won't allow Muslims. And so I just want to tell you that sickness and disease does not know anything to do with religion or anything. So, and because Christ Catholic is universal, so we welcome everyone. We look at the face of God. We look at that we are all created by one God, and we don't look at religion at all. We take history to know your religion for one reason, medical reason, that in case you are at the verge of maybe you need a priest or you need a pastor or a hajj, so that we can help you to address those issues, because we know it's part of our care that we keep you linked to your God. We don't say this is a facility for Catholics. No, it's open for everyone. And even in our trainings, we don't specifically look for training only Catholics, or we just train, we look at service. But when they come in our facility, definitely we have values that stand out, that to say that this is a Christian facility, that there's no question. So if you are a health employee with us and it's time to say together we gather and pray before we start work, definitely you have to abide and we pray together. So teamwork is very, very important that we use, and Christ is our icon. We treat and Jesus heals.
Amen. Amen.
Yes.
Thank you very much for that. And maybe the last one, or the second last, sister.
Sure.
You were a hospital director.
Yes.
You were up there. Hospital, well-founded, with a history, and here you are, going back to the grassroots. I mean, to me, that is just amazing. That, and it shows how committed you are to start building another hospital from scratches, basically. What message do you have to doctors like myself out there who think they have reached or they have arrived? Just what do you have to say about that?
The truth is that the gospel gives us all the guidance. Blessed are the poor. Why don't I be identified with those that are underserved? Another thing I told you, my publications, to make the quick ones, that the one that has brought me here, you wouldn't maybe see me if I had not worked with the poor and the underserved in the community. And them themselves, they will give you a status. If you serve the poor, if you serve the community, themselves will give you a status. I have to tell you that there are many professors of mine who taught me even, but they have not had the opportunities that I have had because of serving such a communities. So what am I saying? Staying in the city is okay, but right now, for example, I'm the president of the Gynecologists, but I still feel I need to train. That's why I'm St. Francis Hospital, trying to teach interns, and I persuade them, give them a spirit to go where they can do real work, and that is in the community. And for example, my mother, I wasn't delivered in hospital. It was on a small heart and by herself. So if I was lucky, I did not become a fresh stillbirth. So right now, my responsibility is to train more people, help more people in a Christ's way to go back to the community and serve. And once we turn these communities into what is good, everyone will say, no, I think everything is possible anywhere and anytime, as long as we have the will and the love to do it, but also knowing who am I serving? For me, my issue is not who am I serving and where can I find Jesus? If I can find Jesus in the city only, I will stay there. But if Jesus is in the heart of that community, trust me, you'll not catch me in the city all the time. I will run there because I love him and I want to serve him.
Thank you very much, Dr. Priscilla, for motivating many of us, motivating the people out there, and showing that we can serve the Lord our God through Jesus Christ, his Son, wherever he has sent us. We want to congratulate you upon the work that you're doing. We are proud that you are transforming lives of women and children to ensure that people have a full life, and not just a life physical, but also the holistic life of care. To me, that is very, very important to us as a nation, but also as a person. Maybe in your conclusive remarks, 1 or 2 words, what would you want to tell our viewers there that I may not have asked you, but you feel is in your heart to share?
Yes, thank you very much. That every time we are doing something, let us think beyond of the faces we see. If I see Dr. Tumwesigye, beyond your face, I want to see something different and to make an impact every time I meet someone. Every time I meet a patient, let me know that this might be my last patient, or this might be the last thing I'm doing, so let me do it well with all my heart. They usually say that it's better to plan as if the world is not ending, but work as if it is ending today. So I would say, viewers, please, let's work hard, but keep looking beyond the faces we see. And as Christians, let's seek to serve God. And God is everywhere. And we can find God everywhere, but especially in the poor and underserved communities.
Thank you very much, Dr. Sister Priscilla. With that, viewers, I want to take you back to Allison Flynn to continue where she had ended. So thank you very much. It was a pleasure interfacing with you, sister, and our viewers. Over to you, Allison.
Thank you. Thank you very much.
Thank you so much, Dr. Tonny and Sister Dr. Priscilla. Wow, just so inspiring, and so many good things that I wrote down during that conversation. Just even being reminded that everyone is important, and that the community, the elders, the people in the community do have ideas, and they can not only identify problems, but we can work together to find solutions. And so, yeah, thank you so much for sharing from your wealth of experience. We're going to move to our next presentation, which is looking at applying lessons learned from COVID community mobilization to prepare and respond to future disease outbreaks with religious leaders as health champions. And we have a few different panelists who will be sharing with us. And so we have with us Nkatha and Njeru, Emmanuel, Kongnyu, and Kelechi Utoware. And so first I'll introduce to you Nkatha and Njeru. She's the ACHAP coordinator, and she'll moderate this next panel. Nkatha Njeru is a public health professional who has worked with the faith sector in Kenya and regionally for the last 17 years. She has extensive experience in health system strengthening, where she's worked to support nonprofit organizations, mostly faith-based health systems, in organizational capacity development, policy formulation, strategic planning, human resources for health, as well as health financing. She's the team leader for the Africa Christian Health Associations platform, or ACHAP, which is an umbrella organization for Christian health associations with membership in more than 30 African countries. And our two panelists include Kelechi Utoware,
who is a professional social worker and a mental health expert. Sarah has worked for over 10 years across multiple crisis interventions areas in both large and small capacities. In the past year, she's worked with both Christian and Muslim leaders in COVID-19 community mobilization. She's currently working with the Christian Health Association of Nigeria as a program officer, and Ms. Utoware is pursuing a master's degree in public health. Another panelist is Emmanuel Kongnyu, who is the IPC and WASH Supervisor for the Cameroon Baptist Convention Health Services. Mr. Emmanuel is a seasoned nurse, screener, and teacher, and an experienced public health professional with a church in Cameroon and Africa. He has experience in the management of programs and projects in the hospital and in community healthcare, curriculum design and IPC and WASH, healthcare strengthening, outbreak prevention, and epidemiological disease surveillance. He is a member of the Infection Prevention African Network, or ICANN, and one of the founders of the Infection Prevention and Control Association of Cameroon, and is the organization's Secretary General. So I will hand it over to Nkatha to lead this next panel. Thank you so much. Go ahead and unmute yourself.
Thank you. We'll have a session played. Good morning, good afternoon. Welcome to this session. My name is Nkatha Njeru from the Africa Christian Health Association platform, ACHAP, based in Nairobi, Kenya, an organization that works with Christian health associations around the world. My two colleagues are going to introduce themselves. Let's start with Kelechi.
Thank you. Good morning, good afternoon. Yeah, good evening as well. My name is Kelechi Utoware. I work with the Christian Health Association of Nigeria as a program officer. Yeah, I think that's it.
Emmanuel.
Good morning, good afternoon, good evening. I am Kongnyu Emmanuel from the Cameroon Baptist Convention Health Services in Cameroon, and I'm glad to be here.
Thank you. Thank you, Kelechi and Emmanuel, members of the Africa Christian Health Association platform. So today we have the task of discussing the application of lessons from COVID community mobilization to prepare and respond to future disease outbreaks with religious leaders as health champions. As you may know, Christian health associations are really organizations that are formed or work together with churches. We are the health arm of many of our churches. And so in our work, we tend to work with our faith leaders, not just Christians, but other faiths as well. So my colleagues will be discussing the response that they have recently had to COVID-19 and thinking about ways and reflecting on ways that we could take these lessons to prepare for future pandemics. So the first thing I want to ask is to Emmanuel. Emmanuel, how did you work with religious leaders to mobilize them as educators and influencers in their congregations or their communities? How did that work? How did you enlist them? What kind of resources or trainings did you give them and support that you provided? How would you envision being able to use this to scale up such in future outbreaks? Whatever preparations you had, how did you work with them?
Thank you for that question. It was a very interesting moment to work with church and faith leaders in Cameroon. We were able to get not only to pastors in different churches have different appellations. Some call them deacons, some call them elders, whatever they call them. We were able to engage them church by church. Like in the Cameroon Baptist Convention, we were able to pass through the lead, the head of the church, who happens to be a pastor, who was also able to mobilize these church leaders, bring them together in different locations, and we were able to teach them using all the available resources we had, such as we have stations with PowerPoint presentations where we did demonstrations of essential things like hand washing, wearing of masks, training them as trainers, and they were able to go back into their various churches, to their various congregations, and replicate what we taught them. And the result was that in the first phase of COVID-19, many of these lessons that we learned were we taught them, the things we taught them, the effect was not much felt. And I think in future, we will be able to replicate the same thing and be able to go ahead to go even into little organs in the church, like the youth organs, the women, the men, the children, engage their leaders into such activities in order to get better results.
Thank you. Thank you very much, Emmanuel, for that explanation of how you prepared. Kelechi, I would like to ask you about passing on information to the religious leaders. Many have commented that along with the COVID-19 pandemic, the world was faced with an information pandemic, and disinformation often crowded accurate information. Did the religious leaders that you worked with face this challenge, and what did you learn from this?
Okay, thank you. Yes, the religious leaders we worked with faced this challenge. For CHAN, the initial point, we engaged only the Christian religious leaders, because in Nigeria, the other faith had a little challenge believing, coming to terms with the reality of COVID. So it was majorly the Christian religious leaders, and they faced that challenge of misinformation, because even our public health agencies were giving us different reports. You know, today we hear it's communicable, tomorrow we hear it's not communicable, and all that. So it's really, at some point, brought a lot of confusion and doubts, and a lot of course, teachings on exclusive faith healing, and it really, to some extent, caused some damage. But what I learned from all this is that we're able to maintain our consistency. What we said from the beginning was what it was, even till now. And I think in some way we are still back to what we started with. You know, there is really no discrepancies and all that. So I learned to be consistent. And yes, the religious leaders faced that challenge of misinformation. It was real.
Thank you. Thank you. That is definitely something that happens in a situation where we do not know where to what to expect, or where people are still learning the science. And I think consistency, like you said, is very important. And very important too was, I think what you have mentioned before in our discussions, is being able to consider sources such as the World Health Organization as a source of information, which was very helpful. And the fact that we were also able to produce materials from time to time that were guiding the religious leaders. So thank you. Emmanuel, looking back at how you worked with religious leaders in community outreach on COVID, what would you hope to be able to do differently if faced with a similar challenge in future?
I think that in future, we need to be more careful in the way we approach people, because one of the things the church did this time around was the church was too slow to enter into the various churches and congregations with the appropriate information, and then they were crowded by wrong information. The first thing the church should do if we were to have such a pandemic in future is that once we get an alert that there is such a pandemic, the church should work faster with the appropriate information, get it into the churches before false information comes into play. I think that is one of the first things we want to do. I also want to think that we will not wait until pandemics come before we begin to run around. I think we should now make it part and parcel of us to begin to teach church leaders about outbreaks, begin to teach church leaders about what to do if there is an outbreak, begin to teach church leaders where to get the right information and how to get it, begin to teach them on the various communication skills so that they will be able to disseminate the right information all the time we have an epidemic, because in the various villages, in the various towns, the voice of the church leaders is key to many people. And once the church has gotten the right information and at the right time, the various communities are going to have the right information. So if we were to have such a pandemic, I think that is how I'm going to approach it. But I'm still going to emphasize that we wait for the things to come before we act. I think we should be more proactive this time around to begin to teach the people even before outbreaks surface. If we make during our church trainings, our Bible conferences, one of the things we can engage our Christians as well as Christian leaders is issues about outbreaks, issues about pandemics, how to get the right information. If we do this before an outbreak comes, we will be on the right track. Thank you.
Thank you, Emmanuel. Very insightful. It's always said that a community is as informed as its leaders, because leaders are at the forefront. They are gatekeepers to communities. So very insightful that we need to start engaging our communities about health long before. And like a previous CCIH session last week, one of the moderators mentioned that we need to take our place as faith-based health organizations, as the go-to organizations for churches for information. So thank you very much for that insight. I'm going to go back to you, Kelechi, in Nigeria, and ask you about how have faith leaders been effective to in combating stigma and discrimination in their communities? How effective have they been? I know you have been working with them very recently on HIV and AIDS and stigma and discrimination. And I know we had a lot of instances of stigma and discrimination, even with COVID-19. So how effective have religious leaders been in combating stigma and discrimination in their communities? And what role do you think they will continue to play towards elimination of stigma and discrimination?
Okay, yes, the faith leaders have been very, very effective because the faith leaders have this great strength and grounded communities where they can make their impact. So I see it as, I see them being very effective through their sermons of love and hope. And this love and hope, of course, is to be given to both the affected and the infected. And this is opening the way to reconciliation, healing, knowledge, protection, and care. So, and they also do, and by their sermons, they also have provided moral support to the community. However, there are limitations to our faith leaders. There are limitations, particularly when it comes to denominations or congregations. Once the head of a denomination or a congregation does not believe in a thing, it becomes difficult for other leaders who are under that denomination to speak exclusively on that matter. So these are the limitations that they are experiencing. We as CHAN are also experiencing. But on the whole, apart from these limitations, they have been very, very effective because they get to use their pulpits to speak about these things. And faith leaders are well respected in every community. So they have their presence, they have their respect, and they're able to pass messages. And when this kind of messages are passed, more than 50% of that population will heed to them. So it's been very effective. For as many as we have engaged as CHAN, they have good knowledge about the situation, and they have in turn been peer educators they have in turn trained so many people to also train others, both formally and informally. Yeah.
Thank you, Kelechi, for that insight into the role of religious leaders on stigma and discrimination. So what I hear from you is that one of the most important things is to start with the leadership of the different congregations, because
exactly.
So a top-bottom approach.
Exactly. It's going to have the trickle-down effects, because if we just start from maybe a regional leader or a zonal leader, it won't really have great effect, because at the end of the day, he might be queried for doing what he's doing once the leader at the top does not believe in it. So we have to really start from the top, and then it gets down to the bottom.
Very, very good insight. I had not thought about community mobilization of religious leaders in that way, but that's something that we need to consider, that we start by working with the religious leaders from the top, that we get the buy-in of the leaders of different congregations, and then we're able to very effectively get down. Emmanuel, do you have anything to add in terms of stigma and discrimination, and anything that you did or what you think we should do in future?
You know, learning from the lessons of HIV/AIDS, from issues surrounding disclosure of diagnoses, how people are being regarded in the community. We had a similar thing in Cameroon, where families were distant because a member of that family was diagnosed with COVID. And the role of the religious leaders was very key. I remember in one of the villages where a relative was diagnosed with COVID far off in town, and one of the relatives went there to take care of him. And when he came back, it was like, hey, are you not sure you brought it? People were running away. It took the influence of the church pastor, the local church pastor, to tell them that this is this, this is that. Because somebody has COVID, it could be you. And he did that in the congregation. And one thing I learned from them, which I think we should replicate, is people feel comforted and people feel belonging when their church leaders talk to them about issues concerning them. And once they have listened to their church pastors, the degree of discrimination and stigma starts to drop sharply. So if we organize more training to church leaders on stigma and discrimination, that would be great. These are things they might not have been drilled on when they were in the seminary, because they focus on issues about faith and practice, but now it has become part of their job. I also think that we should not think that because they are pastors, because they are church leaders, they already have the knowledge to manage issues of stigma and discrimination. I think that once in a while, they also should be brought on board and trained on these issues about stigma and discrimination, because they demonstrated during this period of COVID that their influence over the people to train and to follow up and to counsel on issues of stigma and discrimination was very, very critical. So that's what I think in my point, that we should begin to look at these things early enough before we even reach where we are today.
Okay, thank you, Emmanuel. Kelechi, as a last word, who do you think faith leaders should partner with in communities to be able to face future pandemics? Any examples even from what you did, very briefly?
Yeah, sorry, come again. What example? I think
who do you think, and even Emmanuel, if you have examples of partnerships religious leaders could have that could help them work in communities on future pandemics?
Yeah, I think, yeah, for partnership, I really think that the Muslim religious leaders should be partnered with. It's very key, because I just discovered recently, we as CHAP just discovered recently that the Muslim faith here in Nigeria have some health facilities, a few spread across the nation. And I think, just like I said earlier, the leaders need to be sensitized first before we go down. So I think
you mean Muslim, working with the other religious leaders. Okay.
Yes, thank you.
That's a good one. And thank you for those insights into working with religious leaders, what we need to do, how we need to engage them, top, bottom, and making sure that they have information, because if they are not well informed, our communities will also not get that trickle down information, and they are always with our communities or with people, so they're an effective champion to whatever we want to get down to communities. Thank you very much for engaging, and we look forward to being better ready if there is a future pandemic, and thank you for everything that you do. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you so much to Nkatha and Sarah and Emmanuel for that panel. We are going to move to our next presentation. Just as a reminder for everyone, I believe you've been doing this well already, but just a reminder to put your questions in the chat box below that you'll see down there. And we will compile them and share them together at the end of all of the presentations, where we'll have some extended time for question and answer. So next, we will see a video with Dr. Laura Smelter, the Director of Training at Christian Health Services Corps, discussing the community involvement and ownership of maternal and child health programs in the time of COVID-19 in Haiti, along with Dr. Bibiana McLeod, a missionary with Medical Ambassadors International. Dr. Laura Smelter serves as Director of Training at Christian Health Service Corps, a healthcare mission, sending, and training organization. Her career as a family physician has provided national and international, rural and urban, clinical, academic, and administrative experience. This has included service as the Family Medicine Residency Director at the ECWA Hospital, Egbe, Nigeria, and Clinical and Community Health Program Manager for Samaritan's Purse in Haiti. Dr. Bibiana McLeod is a missionary with Medical Ambassadors International. She is the founder of Medical Ambassadors Haiti, which is today an independent NGO fully managed by Haitian nationals. MAI Haiti focuses on training communities in community health evangelism. And she's now MAI's technical advisor for disaster response, human trafficking, and 1,000 days in Haiti. So we'll go ahead and look forward to learning from them in this video.
Hello, Bibiana. It's a pleasure to talk with you today and learn from your over 30 years of experience with Medical Ambassadors International and community health evangelism. So I'm wondering about how you have used the CHE model in the 1,000 Days program in Haiti.
Hi. Yes, I want to share a little bit of what CHE is first, so people will understand. CHE goes for community health evangelism, and it's just a strategy of community development. So we have certain core values, like community ownership is a good one. Another one is development instead of relief. Another one is integration of physical and spiritual. So when you think of all this and you think of 1,000 days, that is the health of mom and child from conception to 2 years of age, then you say, okay, how do you integrate that? The story goes that we have been working in Haiti for many, many years. And then one of the facilitators in the community said, you know what, there are children with malnutrition in this community that we have been in for many, many years. And we started to investigate, okay, how can this happen? And we said, okay, we can offer to check the health of the children and then have a community meeting and talk with them about what is happening. So that's what we did. We checked the blood for anemia with a very simple centrifuge and checked the height and the weight of the children, measured, got the standard deviation, got the statistics for the community, and then we sat with the community leaders. So that's the process that CHE does. And ask them, okay, what do you think that we should be doing? Where is the problem? And also we talk about the damage in the brain of children that suffer malnutrition in the first 2 years of age, and how can it affect their learning ability. And immediately they were on board, and not only they started to develop ideas, but they started to monitor their children every month. So they really took over the whole process.
That's a great example of community ownership.
Mm-hmm.
How has the program had to pivot during COVID?
Well, I'm talking specifically about a particular country, Haiti and COVID. I was in Haiti when this happened, when it was declared a pandemic. And by March, we had to decide to leave the country, and we had taught them how to make masks and how to prepare disinfectant. But what is interesting is that when you go to the statistics, COVID has not been big in Haiti, and all the restrictions and everything have loosened up after a few months. When you, like this morning, I was checking just for this interview, and there are a little bit under 13,000 cases since COVID started, and 250 deaths in a population of 11 million. So really, we don't know why. When you try to find out, okay, why COVID was not of big impact in Haiti, nobody can give you a straight answer. Yes, there could be under-recording or under-reporting, but my colleagues that are working there, they don't see it. They don't see it in the communities. So what happened is at the beginning, okay, they all stopped training and face-to-face, and of course there is no internet for Zoom calls. And then little by little, they started to loosen up. But one thing they did at the very beginning was they prepared a superfood that is done with 3 types of flours, and they distributed it with the children that are in the program with addition of moringa. And they only did it once. But in the monitoring, we have not seen a decrease of the nutritional status of the children. So we see improvements even in the midst of COVID, and COVID has not impacted the program as much because they are still monitoring every month. Yesterday, they sent me the report for the first quarter, and I see that there are 30 communities doing it right now.
That's wonderful. And it really sounds like the community has had engagement and ownership through the origination of the program, as well as pivoting during COVID. Do you have any closing remarks about that community ownership and engagement?
Yeah. You know, when you say engagement of the community, many programs try to convince the community to be part of the program that we carry with us. And in CHE, we try the opposite. The program is yours. If you want it, we are here to walk alongside with you. But we are not going to tell you that you need this program and I should do it with you and you should take part in it. It's so the opposite. I want to say that even when we have a good strategy and best practices, it's years of a trust relationship. So you may have a very good strategy to work with community participation, but all in all, I feel that it's relationships, and the relationship with the community makes it happen. So the community takes the initiative. And I think that this is what has happened in this 1,000-day program in Haiti. And the team has been there so long with the people that people trust them, and they come and ask questions. And we are training the birth attendants in the same way with this trusting relationship, of working with a hospital in a trusting relationship.
That's wonderful. I really like how the trusting relationship allows co-creation.
Yes.
Thanks for sharing with us today.
Thank you for having me. Have a good day.
Wow, that was a great conversation, and I loved how that ended, just thinking about relationships and how important relationships are. I think that's something that we have been seeing come throughout many of these different presentations that we've had today. Next, we have a friend of ours from Tier Fund who will be talking about sharing visions, partnering with service providers and faith-based organizations to shift social norms for health and equity, experiences from DRC and Rwanda. So Olivier Bizimana is a Passages Project Coordinator in the Tier Fund Rwanda office, and he oversees scale-up support for MFF, which is Masculinité, Famille et Foi. My French is not so good, but he has been a professional community development worker for the last 8 years and promoted gender equality for women and girls. He is committed to working towards the economic and social empowerment for vulnerable communities, such as the elderly, people living with disabilities, refugees, and other key populations, especially in Rwanda, Burundi, and the Democratic Republic of Congo. So, Olivier, very happy to put it over to you to unmute and share with us about your presentation.
Thank you so much, Allison. Thanks for having me. And let me acknowledge the massive impact that we've had from different speakers who spoke before me in Nigeria, Uganda, Cameroon. So thank you so much. So I'm going to talk about partnering with service providers and faith-based organizations to shift social norms and for health and equity. And the focus shall be, as today's theme, community ownership and co-creation. So next slide, please. So in this presentation, I shall talk about how Passages Project supported 2 organizations to adapt and integrate the project into their existing work. And here, one thing you have to understand, as some of you, as Allison, I think that her French is not that great. So masculinity, faith, and family, or masculinity, family, and faith. So that's what is called MFF in full. MFF is an acronym. So this is a project that focuses on reduce intimate partner violence and improve health timing and spacing of pregnancy through addressing inequitable gender norms. And this project was first implemented in Kinshasa, DRC, in 2016 in partnership with ECC and the Georgetown University Institute for Institute for Reproductive Health. And so following the pilot phase, we also introduced the talk on scale-up opportunities in Rwanda, and it was introduced in Rwanda through a scale-up workshop in Great Lakes. And that's when we had the Scale-Up Great Lakes workshop in October 2019. And next slide, please. So following the Scale-Up workshop that was introduced in Rwanda, we also explored opportunities of how can we scale up masculinity, family, and faith into Rwanda. And this is the overview of the model for MFF. And the entry point here, we aim at transforming faith leaders. As some of the presenters have highlighted that, you know, faith leaders are very influential. So the entry point for this project is the church. And we equip the church to bring forth the change into their communities. And after equipping the church, they are the ones to help us also identify community and faith members into the church, and who then are equipped and trained on MFF interventions, and they are called gender champions. So gender champions, as they are part of the church, And so then they are the ones then who facilitate community dialogues. And these community dialogues are intended to reach out to community, and the focus here and the target here are newly married couples and first-time parents. And the community dialogues are of a period of 9 weeks. And in order to reach to the wider congregation, we also introduced different activities that are so-called diffusion activities, such as story sharing by couples, community mobilization events, and celebration events as well, and supportive sermons and calls to action. And lastly, that is very important in order to foster the health linkages, we also establish connection between health providers and the churches. And this is done through establishing first the health linkages, where a health worker comes to the week 8. As I said, it's done through community dialogues of 9 weeks. And on 8th week, a community worker comes in and gives a health talk on how they can access family planning, modern family planning methods, and also referral cards handed out to the couples that are following the community dialogues on how they can access counseling support and also family planning methods after the community dialogue talk. Next slide, please. So following the Great Lakes scale-up workshop that I said that happened in Rwanda, different organizations expressed their interest, and 2 came out of many organizations in Rwanda, came very strong, I have to say. And the next slide, this one we are seeing here, is about why did we choose these partners. And so first and foremost, let me define AMU in full. This was one of the 2 selected partners in Rwanda, implementing partner for the MFF intervention. And AMU in full is called literally Beloved Child Association. And their focus here, they have networks with churches. And it's an organization which is even faith-based organization. And also, so they saw MFF as a tool to answer gap to addressing harmful social norms, especially during COVID. It was seen as a great need to address harmful social norms into their context. And also AMU, as I said, Beloved Child Association. So MFF intervention as a pathway to integration into church and community transformation. One of the programs that the AMU project in Rwanda partners which do implement MFF is church and community transformation. And acronym, please take note of it, CCT. You will hear it a lot throughout this presentation. They are working with 107 churches in Rwanda. And the second organization which was selected is HDI. HDI in full is Health Development Initiative, and their approach is a right-based approach. And they were also selected because of their strong work they are doing on family planning and reproductive health. And they saw this as existing focus on family planning and GBV. And one thing we have to point out here is that HDI took MFF, which is masculinity, family, and faith, as an entry point to work with faith-based organizations as a complementary element to existing human rights approach. Next slide, please. So as today's theme, we are focusing on community ownership and co-creation. And this is how the 2 organizations and how Tier Fund has supported the 2 organizations to adapt and integrate MFF into their existing work. And here, during co-creation first, it was very important to first build the capacity of 2 organizations by first, introducing what is MFF. So for them, for each organization, it was very important to identify scale-up opportunities into their respective spaces. And also one thing that was very important during the co-creation right from the beginning because the project was all along designed to accompany partners on how they can adapt and integrate MFF into the existing work. So from there, we had also some component that was very important during the co-creation phase, that is institutionalization within organizations, where different talks and meetings were conducting within respective organizations to organizations on the knowledge of the project, where can it fit? And from there, we also had a significant part of co-creation, which was the local government ownership for this project. Let me explain here what we meant by ownership of local government. So the local government in Rwanda saw the MFF indicators as a solution to addressing GBV cases in our context. So they took the indicators of MFF and incorporated into their action plan, because as a result, because it came as a solution to existing issues in the community. So moving on how did AMU, which is the Beloved Child Association, scale up their vision into the existing work. This is very important as part of co-creation phase. They took MFF intervention into the integration into self-help groups. So here AMU is working with self-help groups, and they selected members of the community dialogues to be part of that journey. So this is very important, which we shall come to see later on, that they integrate the MFF into their existing work through self-help groups. And secondly, which is very important, was during the recruitment of gender champions. So here, AMU not only chose and recruited faith and community and church members, they also selected local leaders into the community to be part of gender champions as part of co-creation right from the beginning. And let me note that this is a significant difference between how we integrated MFF work in DRC compared to Rwanda. In Rwanda, AMU was intentional in recruiting both faith leaders as part of the journey, but at the same time, community leaders, right from the beginning into the selection of gender champions. For HDI, the second organization, which is Health Development Initiative, in their scale-up vision, I have to note that they were having a strong work that we are doing for reproductive health and family planning. So here, what they did was to integrate the topics, programs, and of MFF intervention through radio talk shows. So these were existing channels in Rwanda to air talks around family planning and reproductive health. So they took MFF topic into the existing GBV programs. And one thing that was very important during the co-creation was the establishment relationship between faith leaders and community and health providers as well. So this was a great idea that was also seen during this co-creation phase. Next slide, please. So this is a very important element we've seen during the MFF journey right from the beginning, was the community ownership. How did we see the element of community ownership? We saw it especially during COVID. And we saw a great and incredible commitment from faith leaders who helped right from the beginning to find new sites and intervention activity despite COVID limitations. Here, what we've seen is we saw the global crisis of COVID and how it was evolving with the measures that were ever changing. But the faith leaders right from the beginning showed commitment by finding new sites on where to conduct community dialogues. And one thing that was very important during the community ownership was the cascading change. Here, what is very important, as I pointed out in my previous slide, was the integration of MFF into self-help groups. These are groups for savings. So, and here the couples, when we say participants, we mean newly married couples and first-time parents. Some of the participants of community dialogues were also part of self-help groups. And how did we make sure that there was community ownership? They were selected purposely to be agents of change. So later on, they were the ones also to cascade the knowledge on how to address harmful social norms into community as agent of change. This is very important to ensure that community ownership was done. And also, this is a significant change we've seen during the community ownership was the change churches creating their own committees and structures. So the other day we had a scale-up workshop where denominational leaders were invited and they committed to scale up the MFF intervention into their own structures and also beyond the selected churches. Now they will be disseminating MFF intervention into new 60 churches. And some of the great examples we've seen was the focus that shifted now. They've created committees and subcommittees and also to integrate MFF into department ministries such as Mothers Union, Fathers Union, and Family Fellowship Ministries. Most denominational leaders also saw this as an opportunity to introduce MFF to pre-marriage couples during the sessions. Next slide, please. So we talked about community ownership and co-creation, but what are the lessons learned? As I said, COVID was a massive barrier to the implementation of this project. Nevertheless, we've seen a high interest engagement from faith leaders and faith communities. For instance, some people used to come to the community dialogues, though they were not invited, listening through windows, you know, and this was very important as a high interest, and also the engagement of faith leaders to make sure that the community dialogues were conducted. We also saw strong partnership between church and service providers. And this was seen through the linkages that were created through also memorandum of understanding. So during COVID, it was very important that we implement MF despite all the barriers due to COVID, but there was adaptability and resilience of churches. This was very important, which I have to acknowledge. And this happened because of targeting first denominational leaders. They were the ones to help us into institutionalization of MFF into selected churches, and also to make sure that the project is running into all the sites. And this was very seen also for the key role. That's what I wanted to point out. And lastly, and which was very important as a challenge, was the remote support. Since the travels were banned across the globe, there was only the remote support, and which was also reduced the implementation due to COVID-19. Nevertheless, opportunities came out of COVID because COVID was gendered. And that's something also to talk about maybe in our break out rooms. What are the opportunities we've seen in the midst of COVID-19? Thank you so much for listening.
Thank you so much, Olivier, for sharing with us. That was just really so interesting and great to learn about, and some fodder for some of our Q&A time that we will be having at the end of our presentations. So that's just a reminder to everyone to please, as you think of questions, as you hear different presentations, feel free to put them in the chat box, and we will be answering, having them all go together at the same time at the end. So we're going to transition to our next panel, which is on cultivating community ownership for sustainable maternal, newborn, and child health gains. And our friend Nancy Tenbrook will be facilitating the panel. But first, I'll introduce our panelists for you. So Nancy Tenbrook is a senior program consultant with World Renew, serving in Bangladesh and in India. Ms. Tenbrook holds a Bachelor of Sciences in Occupational Therapy from Eastern Michigan University and an MA in International Development, Health and Health Promotion from the University of London in England. She currently works as a field staff member in directly implemented health projects and consults with assigned partners in Bangladesh and India. Her overall focus is primarily in rural community development and helping partners carry out these health programs in communities. And then sharing with Nancy today will be Sadok Aguilar. Sadok has a bachelor's degree in socioeconomic and environmental development and a master's in local development and tourism. He has over 15 years of professional experience working with government agencies, private companies, and INGOs in the fields of agribusiness, food security, organizational capacity building, health and nutrition, microfinance, and community organization. So just to name one. He is the country director for World Renew in Guatemala, currently working alongside faith-based grassroots organizations which are supporting rural communities with their transformational journey. He's an advocate of asset-based community development and of servant leadership as key approaches for sustainable community development. And then along with these two, we have one of my friends here in Malawi, Lemon Chipwatali. Lemon has over 15 years of experience in relief and development work in organizational strengthening, health and nutrition, livelihoods, education, gender justice, food security, and emergency response. Lemon has worked with communities and partner organizations in the care group model and in nutrition, integrating nutrition into livelihoods projects. He's stationed in Malawi and works with World Renew on the Southern Africa team as a regional consultant for health and nutrition and capacity development. Mr. Chipwatali has an MPH and a BSc in family science. So I will hand it over to Nancy to facilitate this next section. Thanks, Nancy.
Hey, good evening. I'm delighted to begin this session. My World Renew colleagues, Sadok Aguilar and Lemon Chipwatali, will be sharing on MNCH health programming in Guatemala and Mozambique. These two World Renew country programs in MNCH are part of a 10-year foundation grant that World Renew has with a programmatic focus on the development and delivery of strong program designs in 8 countries. The goal is to reduce child stunting by promoting specific health practices during the first 1,000 days of life. The emphasis is on capacity building and community ownership. Countries selected were those with high mortality rates for mothers, newborns, and children from preventable, treatable conditions and unacceptable levels of child stunting. We divided the 8 countries into 3 tiers. The basic tiers were for countries where World Renew and local partners had minimal experience in health programming, but there was high need. The basic plus tier was for World Renew countries with some experience and staff and partners could expand their work. And then the comprehensive tier was for World Renew programs and partners that had already strong health programming and could go to scale. Both Guatemala and Mozambique were in the basic tier for World Renew, and they've just completed 4 years of programming. As you will hear from our 2 speakers, the basic package focused on interventions that included appropriate nutrition for mothers, infants, and young children, preventing diarrhea, malaria, and pneumonia, and treating illness episodes by learning to recognize early and then seeking appropriate care providers. Interventions were selected within this basic tier that will be shared in more detail by our 2 speakers. This has been a learning experience for World Renew as we seek to expand our work and experience in MNCH. We'll first hear from Sadok Aguilar, our World Renew country director in Guatemala, and then from Lemon, who will speak on the work in Mozambique. So over to them.
Hello, everybody. My name is Salok Aguilar, and I'm the country consultant for World Renew in Guatemala. It's a pleasure for me to be in this event sharing about the experience of our MNCH program that was done between 2017 and 2020. First, I'm going to start with providing some context on the project. So first, our project was implemented with our local partner agency, ADIP. This partner agency did not have any previous experience with MNCH, so there was 1 year of preparation. So actually we started in 2016, but that year was basically just training that was done to our partner. When that was completed, then we started doing the implementation at the community level. And when we reached those communities, the structures that had somehow a relationship with health were the Community Development Council, the Parents Committee, a community facilitator, which is a volunteer that is paid by the Ministry of Health, and the midwives. During the implementation of the project, or what was developed by the project, was the community health volunteers. Since we're implementing the care group model, well, that involves mother guides or mother leaders, which you call community health volunteers, that would train group of mothers, right? And those group of mothers were called the mothers group or neighborhood groups. Why? Because those mothers would usually live close geographically. That would allow for them to meet easily once or twice a month. And the other structure that was developed as a result of a MNCH program was the savings groups. So those mothers groups, after a certain period when they had developed good relationship, there was good trust being built, then trainings were provided, the option of developing savings group, right? And most of the groups did accept getting training to turn into just mothers, a health group to a savings group. The relationship of our partner before the project with the Ministry of Health was not very strong, meaning that they would not meet regularly or have contact with the local authorities of the Ministry of Health. They would usually just connect with maybe the nurses that would go to the community or with the community facilitator. As with the communities, they were also just more of recipients of the services than really being proactive or advocating towards the Ministry of Health and things related to their health. During the program, though, the relationship changed. For example, with our partner, because they were more in contact with the local authority. The local authorities endorsed the project. It seemed more like collaboration between both organizations than like competition or replacing the services of the Ministry of Health. And the communities were more had more collaboration. They were involved more with the requests made by the staff of the Ministry of Health, who were also more proactive in demanding the services to the Ministry of Health. It was important to build community ownership with this project, and a way to do that was by involving the community leaders, the Ministry of Health, endorsing the project, as I have previously mentioned, the community health volunteers that were identified, but the partner were approved by the community. The faith leaders and the churches were involved in health. So in this project, so they were involved during the meetings when they were discussing the gains or the plans for the year. We wanted input from the faith leaders and their opinion, and also connecting faith with health was very important. And the integration of this health project with other programs or projects that were being done in the community. So for example, with the program of food security of sustainable agriculture. So at the end of the project in 2020, there was an online survey done, and we did see changes, positive changes. So there was an impact in the reduction of child malnutrition, especially with, well, there was a decrease definitely in moderate malnutrition and severe malnutrition, 0 to 23 months, as you can see, went from 16% to 5.3 and from 3.4 to 0. Now, also the number of meals into children between 0 and 24 months also improved. So that was a very significant change. And that was a result not just of the trainings related to health, but also in the integration of the program of agriculture. And another aspect that was also impacted was the health practices itself. Like we had people washing hands more often, like the 4 critical times. That was also very important to see that change, and that they continue doing it. So what is happening now? We're scaling up this program with our partners, since we already built capacity for the partner. The Ministry of Health continues training the community health volunteers, so they see them as an important asset in the community. The savings group keep working, and women are still implementing all the practices, even though there is no direct supervision. They have gained ownership on the activities, see the importance, and continue doing them. And finally, just want to share quickly of how this project helped with the COVID-19 pandemic. So first of all, the volunteers help disseminate messages to the families in the communities. What was this pandemic about, and what would be the measures that should be followed? With the structures developed, we were able to do an effective emergency response, and the spiritual and moral support that were given to the families was important, and it was thanks to the structures that had been also made through the care group model. Thank you for listening, and if you have any questions, please feel free to ask, and thank you again for your attention to the presentation.
Thank you so much. It's a pleasure to be here. My name is Lemon Chipwatari. I work with World Renew in the Southern Africa Ministry team. I'll be sharing experiences on a child survival project that was implemented in Mozambique, Zambezia province, and the Milanje district, to be specific. So in this discussion, I will take you through a brief background and look at delivery structures that were put in place, and relationships that were cultivated with the Ministry of Health, and how did we achieve community ownership, and also look at what is going on in the communities. So that looks at sustainability. As a matter of introduction, the project was implemented by one of our partners in Mozambique called Anglican Diocese of Nyasa. It was aimed at improving child well-being. It covered one health facility, but it did not cover all the catchment communities under that health facility called Itengwa. The facility has 32 catchment communities, so this project covered 20 of the 32. And the project worked with about 2,000 households. Now, what were the project delivery strategies? One, worked with households. 10 households were clustered together, overseen by a counselor. And then we had another set of volunteers that were specialized. One set looking at children's health, another set looking at mothers who were pregnant. So if that household had a pregnant woman, the volunteer who was specialized in pregnancy would come to provide support. We also provided community-wide health education because we understood that there were other issues that needed to be dealt with at public level. For example, issues of water, sanitation, and hygiene. But again, we also built capacity of local structures because we understood that most of the interventions that were being delivered, they needed support of village headmen and other local leaders. So they needed to understand the areas that would be under their jurisdiction. But again, each community had what we called a village health and water committee. So it sent 2 delegates to the health center to form a health center management committee. So it was important that this structure is well capacitated to handle discussions at higher level. We also worked closely with Ministry of Health because this ministry is an important player in the successful delivery of this project. What were the relationships with the Ministry of Health before? So before the project started, most of the interaction between the hospital and the community was when somebody was not feeling okay and had gone to access medical care. But again, that time, not so many people were going to visit the clinic. And we're talking of a time where somebody gets sick or somebody's child dies, the first thing is to suspect who has bewitched my child. So very poor, healthy seeking behaviors. But now we've volunteers helping at the clinic, and that has helped to reduce the workload on the health personnel. Two, there is a health center management committees, which comprises of management of the health center and the delegates from the community to really ensure that there is quality service delivery. This is also an important structure because at community level, we are raising the demand of health service. So it was also important that we also deal with the supply side. We've also seen government training volunteers, so it's a question of now recognition. When there are child campaigns, Ministry of Health is works with the volunteers, so that's another important interaction that is happening. But also when the Ministry of Health has information, education, or communication materials in terms of posters or leaflets, it's using the same volunteers to deliver to communities. So there is a strong relationship now between the government and community at large. How was community ownership and co-creation achieved? One, through strong collaboration with government and local leaders. Two, strong involvement in identifying volunteers. So it was left to the community to propose names because the communities, they know each other better. Training and awareness, training done at household level, some at volunteer, local leadership, government staff level, and also general awareness to the public. But also, periodically, there will be interface meetings, and this created a platform for community discussions on relevant issues. Two, it gave an opportunity to staff to report back on quantitative data that they collected after consolidation and report back to the community. Three, for communities to share progress in their own way, and this was mainly through looking at trends on mortality and morbidity, but also sharing change stories. And this was important because it allowed communities to celebrate the mean achievements and get energized. The project also appreciated the role of indigenous knowledge in the successful delivery. For example, traditional birth attendants who would be doing home deliveries. So the project had to redefine the role of the traditional birth attendants who are well respected in the community by redefining their role so that they stop home deliveries and start providing counseling, but also accompaniment for pregnant women. Another area that we did was on local advocacy through the community discussions, looking at areas that needed advocacy and how to conduct local advocacy. And what have been the gains? So I'll share snippets of the results that the project generated. There was a positive change across all indicators, starting from early initiation of breast milk, exclusive breast milk, minimum acceptable diet, hand washing, a big increase. And again, you're looking at appropriate illness care on diarrhea, fever, artificial respiratory infection, a big increase. Use of ITN, so trying to prevent malaria. So most households started using ITNs. And these are the things that contribute to child mortality and morbidity. And indirectly, what we saw was because there were reduced cases of morbidity and mortality, now issues of suspecting each other, communities bewitching each other became minimal. So it kind of brought communities together. The fabric was well knitted. There was social cohesion. Now, in terms of sustainability, we see that the volunteers are still working. Communities had established laws to discourage home deliveries. Those are still in place and being reinforced right now. Government still works with the volunteers. And as I had said, that the project was only working in 20 of the 32 communities. Because of the success of this project, we're able to expand to the remaining 12 communities. And this has now allowed project staff to also visit the old sites, but once in a while. And again, in issues of COVID, as we're closing down, some of the project staff were trained in COVID, issues of epidemiology, prevention and preparedness. So they took the same to communities. And now as the country tries to roll out issues of vaccine, it's going in an area where they already understand to say, what is COVID? How do we prevent ourselves and also get prepared in terms of when the cases spike? Thank you so much. Thank you.
Okay, thank you so much. Thank you so much to Lemon and to Sadok and Nancy for that really great conversation. And wow, what great outcomes that they're seeing in results. So now we are going to move into our Q&A session. And so just a reminder that you can stick your questions and comments into the chat box, and we will pull them together so that we can discuss. And so we have all of our presenters, I think, will be turning on their videos just as a reminder, and then I'm gonna just dig into some of the questions we have already. And as new ones come, we will add those as well. So first, I'm gonna direct our first question to our first speaker, for Sister Dr. Priscilla. So we have a question in a comment who said, "I love the message to brand ourselves as Christians." The question is, do you have non-Christian staff, and do they brand also as part of a Christian organization? What do those staff say?
Yes, thank you very much, Allison. Yes, we do have non-Christian staff. We have Muslims, actually. And also we have people who are from a certain sect called, you know, the powerful, who the powerful died. And of recent, we've been saying, how could he die if he was the God? So we have them. And when we have occasions where we gather as Christians celebrating together, they all have to do it and they come. And we don't force them, actually. But once they start working with us, they get the spirit of the system, and then they try to also abide to the rules and everything that we do. But most especially praying together before we start work. When we have Mass, the priest has come to celebrate Mass for the patients, or if it's for their day that there are patients who need a priest, and we put a rota who will go leading the priest for those who want to receive maybe Holy Communion. They do that willingly. Yes.
Okay, thank you so much. We have another question for Kelechi, Sarah Utoware. And so Sarah, this is from Jean Sack. She says, in Nigeria, the Nigeria CDC is supposed to prepare accurate messages and guidance for communities in health emergencies. Perhaps they need better insights from those of you who are working outside of Abuja. Do you have thoughts on that comment?
Yes, thank you very much. I don't know, am I showing on the video? I can't seem to find myself.
We're just seeing an image of your webcam utility, but we're not seeing your face.
I must have touched something. Sorry about that. Okay. The Disease Control Agency in Nigeria are actually taking cue from agencies like World Health Organization, and that is actually the information we get. But from the comments, we'll try to liaise directly with them so we could get very, very accurate information.
Okay.
Hello?
Oh, sorry. I couldn't tell if your sound had cut out or not. Great, thank you. So we have a couple of questions from our last panel that we had. And so Lemon, I have a couple of questions for you. You had our last presentation, so people have it fresh in their minds. So Patricia Kamara says, thank you for the presentation. I'm interested in knowing how the community health volunteers are sustained. Who provides the honorarium or salaries for them, and how long do you maintain them in providing their services to the communities?
Thank you. The program was for 4 years, so we basically engaged them for 4 years. We did not provide a stipend or honoraria if you like it, but we provided some things in kind. One, where they were given backpacks, t-shirts, but also incentivized through community recognition, but also celebrating the achievements or the positive outcomes that were coming as a result of their project.
Okay, and we have one other question for you, Lemon. From another one of our panelists, from Viviana McLeod. If home deliveries are discouraged, are delivery services appropriate in remote areas, and how do birth attendants attain training?
I didn't get your question quite all right, but I'll try to respond to it. So we've worked on improving quality of service delivery at the health facility to make sure that pregnant women are well attended to, one. Number two, we had to go into discussions with local leaders, but also the traditional birth attendants, so that they understand our theory of change, and again, still reinvent their role so that they can still be relevant in the community. So they were open to receive training, but also accept their redefined role to provide accompaniment, but also be there when the women are delivering at the health facility.
Thank you. I think maybe a follow on from that, in the remote areas where you're working, are there adequate or appropriate services for women to be able to deliver, since home delivery is discouraged?
That would be subjective, but in our context, yes, they are appropriate because they're using the health facility that is within the allowable radius by government. So in our context, we would say yes, it's appropriate, but also because of the center management committee that was set up to make sure that there is quality service. So I would say yes, it is appropriate.
Sure, thank you so much. Now we have a few questions that are for the wider group. And so I think I may send it to some specific people rather than making everyone for every question go around and answer. So one general question is, we all agree that working with religious leaders is vital. How do they respond when we approach them to talk about health? What can we do better to build their confidence or support them? I wonder if there's anyone in particular who would really like to take that question. But maybe while
I can
you're
take
thinking
that.
of...
I can take that,
Oh,
Allison, from
perfect.
an
Thank
ACHAP
you,
point
Nkatha.
of view. I think traditionally religious leaders have considered health, the work of health workers. But with time and with engagement, they have slowly come to realize their place in health as part of their mission. And how we can do better in engaging them is, like we said during our presentation, starting out by reaching out to them, helping them to understand health from a perspective of the community and the work they do as part of evangelizing, and providing them with resources that help them to do that. That for us has been the easiest way to do it. For example, we have guides that help them to stand on the pulpit and preach on various health issues, borrowing from the Bible or the Quran, and they're able to talk about a health issue from that perspective. So for us, that has been very helpful, being able to engage them from their side as evangelizing through health. Thank you.
Great, thank you.
Maybe Allison, to add on that, being one of, if I put on another cap of being among the religious leaders, I think most times we start programs or we get projects and we don't involve them from the start. We tend to sensitize the community and don't think that they are also part of the community. So I think most important is to know we have the community which has politicians, has religious leaders, have all these kinds of people. So and then we need to categorize and say, let's also have sessions for them in their groups sometimes. But also when they mix up with others, when we mix up with others, we learn a lot. So I think sensitization of the religious leaders is very critical to think about whenever we have something that we want to do for the community, not only taking announcements to them to use in the church, but they also need to be part of our programs. Thank you.
Allison, can I add something?
Yes, please.
One of the things that we've seen, even as we do the community work at grassroots, the leadership of religious leaders is very, very important. You recognize that if the leadership, for example, a bishop or an archbishop, have not bought in, even at the lower level, sometimes religious leaders struggle to do certain things for fear of being in contravention of the status quo. So even with programs at grassroots, we've seen that is very, very critical, especially on sensitive issues, that champions who are bishops or even archbishops make a very big difference, especially when they have bought in and they are fully supportive of the religious leaders at the grassroots. Thank you.
Can I also add something, Allison?
Yes, please.
Yeah, sure. I just wanted also to talk about how can we approach faith leaders right from the start.
Looks like we're having a bit of trouble with Olivier's audio.
Those are part of the change.
Oh. Sorry, Olivier. Oh, he's unmuted. But I think that point was coming in of engaging them right from the start so they can be part of the change. That's a really good point. Olivia, you're back now. Do you want to try and share again?
Yeah, thank you. Also, one thing that we also found very important was when denominational leaders or faith leaders gave sermons or powerful examples into their own lives. Especially this has also brought change to see that what they were preaching is part of their life. So, and this has just also reminded me of a specific faith leader that was giving a testimony about how he didn't have knowledge on family planning from the start. But when he joined community dialogues, he came to know about family planning methods, because most of the time when you talk about health, especially in African context, it's a taboo, family planning. So to break even that silence, so faith leaders need to live by example into their church. Yeah, thank you very much.
Thank you so much. I have a question for Sadok from Grace Croylan. Thank you so much for sharing the Guatemala story so well. What were some of the key strategies for mobilizing mother groups and communities for health?
Before we do the intervention in a community, we reach out to the leaders to explain the work that is going to be done. We're actually asking for permission and endorsement of the activities that are going to be implemented. So one of the things that we did during those meetings was to present the results of the baseline surveys, kind of to give them an idea of what the situation was in the community, what we found with that survey that we did. After that, we encouraged mothers to participate, to be part of that, to be agents of change in the community. And after creating this awareness, we had to do important work of empowering also the women. So there were already women who were natural leaders, who were leaders in the community, just taking those leaders and training them and strengthening them and empowering them, but also finding those new leaders, especially with young women. So I think that those were the two most important strategies that we worked for in the communities, right? First of all, creating awareness, getting endorsement from the leaders. Secondly, finding those leaders, natural leaders, and empowering them and strengthening their capacities. Thank you.
Thank you. Thank you so much. Great. So I have a question before I stick one to a big group. Dr. Sister Priscilla, we have another question for you. Subira shares, we're happy to learn about the good work that you've done there in Tanzania. They also have hospitals who are serving marginalized and underserved populations, but are facing challenges in financing their health services. So Subira is wondering how you've managed to raise adequate revenues and how sustainable is it, as many people that you're serving cannot afford to pay for services. So some of the ways that you've found.
Okay. Thank you very much. So at first, because the health facility people didn't have money, they would come and get services, and the facility would provide. But later we got partners, and the condition was that can the community also provide something? So we started like an health insurance for the community, where every person contributes something for the health to the healthy care of their homes, and then would get like cost sharing. The partners would give us a contribution, and every family was also supposed to pay something to care for them. So that has helped the facility to keep running, and also it helped them to own the services. So that has been the model we have used, which has helped to keep it sustainable, that they still contribute very little money, but at least it does something.
Thank you so much. Okay. And Dr. Tonny, I wonder if you might also be able to shed some light into this, just from your experience. Oh, you're on mute, sorry. The question is just understanding some of the ways that you've been able to finance this work when the people that you're serving may have difficulty or cannot afford to pay for the services.
Yes, thank you very much, Allison. And Priscilla has already hinted on the community health insurance model, which we are putting to scale. Our approach is that people must own their health care, irrespective of the level at which they are. And we have, especially with our facilities, what has happened is that we know that in every community, there is going to be a group of people who are the marginalized or the underprivileged, and they will never pay anyway, however much you try to push. So we've encouraged hospitals to set aside a Good Samaritan Fund to provide for that particular cohort of people. But also, we receive funding from the government, which funding goes to our health facilities. And it is that fund that helps offset some of those cases that may not be able to pay. So it's a multi-pronged approach where there is the community health insurance, there is a subsidy from government, and also there is a Good Samaritan Fund that is set aside to cater for those persons. Thank you very much.
Yeah, thank you so much. We only have a couple of minutes left in our Q&A, even though there's many great questions I wish we could get to. So I think this one may be our last one, and I'd like to direct it first to Bibiana, though we may have a few others answer this as well. What would your #1 recommendation be to another organization on how to engage communities in co-creation? Bibiana, would you mind going first, since we haven't gotten a chance to hear from you yet? Oh, I think if you can't unmute yourself, then maybe someone from our side. It looks like someone from our side needs to. There we go.
Okay, thank you. Yes, I was not allowed. We do have a whole process of entering the community. So we don't come with a program and install ourselves in the community. We do have a process of exercises like calendarization and points of giving, what are the issues and how many points do you give? So there are many strategies to take time to understand who are the movers and shakers in the community and build relationship with them. So that takes around 9 months to 1 year. And actually it's not the white face that shows up in an African community. We train trainers. So there is a preparation. So we are not in a rush. And that's what we say. The process of community ownership takes 4 to 6 years. That's our experience in dialogue and understanding, and then encouraging and empowering with tools. So it's not a quick fix. You have to be invested for the long run. And yes, it's a volunteer program inside of the community. Nobody gets paid. They do it because they love their community. So you have to identify who are those people that love the community enough to do things for free for a long time. And then neighbors start visiting neighbors, and a local health committee is formed, and they take the decisions, they prioritize. So we walk alongside them in all this process of interactive meetings and participatory teaching. We use the Paulo Freire model. We don't go with PowerPoints or presentations. We just throw the question, let hear the answers and build from there. So we have to train the people to go into that process. And those are local trainers. Many times they are church people that want to do it, because in the church you have those volunteers that want to serve their community, but many times they are the non-believers in the community that want to work together. So we have to work on worldview and the idea of Christians working with non-Christians, and how the love of Christ and the message of Christ is still part of this spiritual and physical transformation that they want to see in their community. So it's really long. But if you have the right tools and God brings you the right people, we talk about the woman or the man of peace that has to be in that community that God has placed. And we always talk about the Holy Spirit having worked in the community way before we got there. So really not us bringing the word of God, because God was already there. We just come alongside and identify the things that he's doing, and we join him. And yes, we do have tools that science has given us, social sciences, just like medical science gave us tools to work in hospitals. So how do you do it? You learn how to do community development with a holistic mind, with the spiritual and the physical. And there are tools to do it. I'm sure that CHE is just one of the many strategies that are out there to do it.
Thank you so much. Maybe I'll have a few more people answer that. Nkatha, maybe can you go next? Just in about 30 seconds or so, what would your #1 recommendation be to another organization on how to engage communities in co-creation?
Involving them from the beginning. Involving the community from the beginning would be mine. Thank you. I'm trying to do 30 seconds.
She's thinking about the time. Thank you. Olivier, do you have a thought you'd like to add in on this one?
Thanks a lot. Apart from involving them right from the beginning, is also to design even post-project, whatever we do, it's about sustainability. Because it's about that, how can the community take it after, the project has ended. So what are the mechanisms that you're putting in place that once the timeline of a project has ended, what are the mechanisms in place so that the community can take up the project even after the so-called organizations are no longer, working in that, location. That's very important.
Great, thank you so much. And maybe we'll just take one more. Maybe Dr. Priscilla, I'll call on you once more since you've inspired us so much today. This may take us back to some of the things we've heard from you already. What would your #1 recommendation be to another organization on how to engage communities in co-creation?
And I think, as we said, most important, we involve them from the start, value them, know that they have a lot of information which can help us to build the project, and see beyond the people, the data people you see something nice beyond that, and seek God in every human being, and then work for him in those very human beings. But also be accountable and transparent.
Yeah, thank you so much. Great.
Can
well,
I add something?
Sure, you can be our last one, Laman. Thank you.
Yeah, so important is to create a platform where communities can sit down and engage, share their vision, agree on their vision, resource mapping, and then how do they get to their vision? So just creating that platform for them to engage, realize that they've got resources, and how do they now use those resources to get to their vision.
Absolutely, that's a really, really good point. Great, well, I just wanna thank everybody who's here on the, who's presented today for just a lot of thought and a lot of really hard work has gone into the not just your presentations, but the work that was a part of your presentation. So I want to thank you for that. I'm going to hand it back over to Mona from CCIH to transition us to our next section.